All right, welcome to The Explainer. I am so excited you're here today because we are diving into some absolutely vital medical data that's going to fundamentally transform how we understand, interact with, and honestly, care for LGBTQIA+ populations. Whether you're a frontline healthcare provider, a clinic administrator, or just a really focused learner who wants to understand the current landscape of medical equity, the data we are going to look at today is incredibly eye-opening. We are going to break down the science, the sociology, and the exact actionable clinical steps you need to provide better care. So, let's get started.
Here's our theory to practice roadmap for today. We'll be moving from foundational sociology in our core terminology into some startling epidemiology with alarming health disparities and the minority stress model, and finally into actionable guidelines with the clinical approach and creating welcoming environments.
Okay, let's dive into this with Section 1, Core Terminology, because language absolutely matters.
First things first, we need to draw a really clear line between someone's internal reality and their external assignment. Gender identity is who a person internally knows they are. It's completely independent of sex assigned at birth, which, is simply the biological or anatomical label that was stamped on an original birth certificate. When someone's gender identity perfectly aligns with their sex assigned at birth, we use the term cisgender, but when it differs, they might identify as transgender. And for folks whose identity doesn't fit neatly into the exclusive male or female binary, we use terms like non-binary. Understanding that identity is internal is the absolute first step to providing respectful care.
Building on that, we really have to look at sexual orientation, which actually has three distinct dimensions: attraction, behavior, and identity. A huge clinical exam tip to remember here is that identity and behavior aren't always perfectly aligned. Identity is how a person defines themselves, right? Like gay, straight, or bisexual. Behavior is who they actually have romantic or sexual interactions with. For example, a man might identify as heterosexual, but he might actually engage in same-sex sexual behaviors, which would clinically put him in the MSM, or men who have sex with men, category. And as you'll see in a minute, that behavioral distinction is a total game changer for medical risk assessments.
That brings us to Section 2, Alarming Health Disparities.
And this brilliantly illustrates why those behavioral distinctions matter so much. The epidemiological statistics objectively highlight a severe crisis in healthcare equity. For instance, men who have sex with men have a 17 times higher risk of HPV-associated anal cancer compared to heterosexual men. 17 times. Because of this massive risk multiplier, anal pap smears and high-resolution anoscopy screenings are highly recommended. But, disparities run both ways. The data also clearly shows that lesbian and bisexual women are significantly less likely to receive routine preventative care, and that includes breast, cervical, and colorectal cancer screenings.
The disparities just keep going when we look at infectious diseases. Gay and bisexual men account for a staggering 68% of all new HIV diagnoses in the U.S., along with 47% of primary and secondary syphilis cases. From a clinical perspective, this means that for patients with high-risk behaviors, specifically multiple partners and receptive anal sex, conversations about preventative measures like PrEP, PEP, condoms, and getting STI screenings every 3 months, that shouldn't just be an afterthought. It literally must be discussed at every single visit.
Now, beyond physical ailments, we are facing a literal mental health emergency. Over 50%. I really want to deliver this statistic with the clinical gravity it deserves. Over half of transgender and non-binary youth seriously considered suicide in the last year. And the crisis extends across the entire spectrum. LGBT youth have a 4 times higher risk of attempting suicide compared to their heterosexual peers. And transgender adults? They face a staggering 40% lifetime suicide attempt rate, which is compared to just 4 to 5% in the general population. Screening for suicidality in these populations is absolutely essential. No exceptions.
Which brings us to Section 3, the Minority Stress Model, Understanding the Why.
So, what does this all mean? Why do these massive disparities exist? For example, why do LGBTQIA+ adults have a 20 to 30% prevalence of substance abuse compared to just 9% in the general population? Well, the answer lies heavily in what researchers call the minority stress model. This is the chronic, high-level stress that stems from either real or anticipated discrimination. It is the constant, exhausting hypervigilance of navigating a world that might not accept you. And this chronic physiological stress isn't just a feeling, it's a scientifically validated mechanism that directly fuels cardiovascular disease, depression, and those high rates of substance abuse we just talked about.
And the heartbreaking reality is that this anticipated discrimination is often proven right, especially in healthcare settings of all places. Just look at these numbers. 27% of transgender individuals have literally been refused needed healthcare. 21% have been subjected to abusive language by the very professionals who are supposed to heal them.
These shocking barriers naturally lead a lot of LGBTQIA+ individuals to perceive clinics as highly threatening environments. The result? They either avoid seeking care entirely, or they withhold vital medical information from providers out of pure fear.
Okay, let's empower ourselves to fix this. Section 4. The clinical approach.
So the crucial point is that we actually have the power to reverse these trends, and it starts immediately with our language. Always, always use gender-neutral language until a patient's identity is clearly established. Instead of saying, "How may I help you, sir?" simply say, "How may I help you?" It costs nothing, but it means everything. Some other high-yield examples? Ask a patient, "Are you in a relationship?" instead of just assuming and asking, "Do you have a wife?" When talking to younger patients, ask, "What are your parents' names?" rather than assuming a standard mother and father dynamic. Once we've initiated that trust through our language, we need accurate data for care. There's a standard electronic health record, or EHR, framework of 3 questions that every single clinic should utilize. First, sexual orientation. How do you think of yourself? Second, gender identity. What is your current gender identity? And third, sex assigned at birth. What sex were you assigned at birth on your original birth certificate? Separating these 3 specific data points allows providers to offer highly personalized care, while also allowing the clinic to accurately monitor quality and health outcomes.
Having that accurate data also helps us avoid dangerous clinical assumptions. Let's debunk a major misconception in women's health right now. The myth is that women who exclusively have sex with women do not need cervical cancer screening. Well, the reality? HPV is easily transmitted between women, meaning pap smears are absolutely required. Making assumptions based on a patient's identity leads directly to those massive cancer screening gaps we examined earlier in the explainer. We see similar, honestly potentially fatal, misconceptions in transgender health. There's a widespread assumption that all transgender people have undergone gender affirmation surgery. The reality is, most have not. You must ask about a patient's natal anatomy to ensure proper care. For instance, a transgender man who retains his natal organs absolutely still needs pap smears and mammograms, and, listen to this, can even still become pregnant if sexually active with cisgender men, meaning contraceptive counseling is required. Conversely, a transgender woman who retains a natal prostate will still require prostate cancer screening. Never assume, always ask respectfully.
Let's move to and see how this builds out into our final section, Section 5, creating welcoming environments.
How do we ensure the entire clinic feels safe from the second someone walks through those doors? Here's an actionable checklist. Number 1, establish and visibly communicate explicit non-discrimination policies. Number 2, implement all-gender bathrooms. This is a massive relief for transgender and gender nonconforming individuals. Number 3, train all your staff. A front desk receptionist using a patient's correctly stated pronouns sets the tone before the doctor even says hello. And number 4, display inclusive health materials. Simple things, like having equal visitation policies or a provider just wearing an ally pin, can literally save lives by keeping marginalized patients engaged in the healthcare system. We have covered a ton of ground today, from the nuances of identity to the heartbreaking realities of minority stress and health disparities. I want to leave you with this final, vital, somewhat provocative question. Knowing these facts, what specific change will you make to your practice today to ensure that no patient ever fears seeking your care? The power to close these health gaps is literally in your hands, through your words, your data collection, and your compassion. Thank you so much for joining me today, for your incredible focus, and for your commitment to learning. Keep asking questions, keep making changes, and I'll catch you in the next explainer.